Okay, let's unpack this. We're dive into, well, probably one of the most high-stakes areas in medicine, really mastering the critical obstetrical emergencies.
Right.
It's not just about glancing at a monitor or treating one symptom in isolation, is it? This deep dive is about understanding that whole interconnected cascade, that systemic collapse that can happen when things go wrong during labor and delivery.
Absolutely. And our goal today is really for the learner who wants true mastery. We're taking some pretty dense professional medical text things covering intrapartum fetal monitoring, shock, acute kidney injury, coagulation disorders, and boiling them down.
Distilling it into that elite level knowledge.
Exactly. Elite level synthesized understanding. We really want to explore how you diagnose fetal jeopardy, get grips with the pathophysiology of systemic shock, and then manage those tough multi-organ failures like disseminated intravascular coagulation, or DIC, and acute kidney injury, AKI.
And what I find so fascinating, and I think you'll agree, is how these seemingly separate issues, a little drop in fetal heart rate or a big hemorrhage or even a severe infection, they all funnel back.
They do.
They all come down to that same fundamental problem at the cellular level. It's hypoxia and the acidosis that follows. That seems to be the core concept, right?
That's the unifying thread, cellular hypoxia and acidosis. We really need to connect those dots for you today. It's key to understanding critical care in this field.
Okay, so let's start at the beginning, right? At the point of trying to detect problems early, monitoring the baby during labor. The main goal of intrapartum fetal monitoring, IFM, seems pretty straightforward.
It is on the surface. You're watching the fetal condition, primarily looking for any signs of hypoxia so you can jump in and manage it quickly.
But the first really important point, I think, is that labor itself is stressful for the baby, physiologically stressful.
Yeah.
Can we, ground this in the actual physics? Why does every contraction basically pause oxygen delivery for a moment?
Yeah, we absolutely have to understand that mechanism. It all comes down to blood flow through the spiral arteries in the uterus. Those are the ones feeding the placenta.
Okay.
And blood flows as long as the pressure inside those arteries is higher than the pressure from the surrounding uterine muscle, the myometrium, squeezing down. So when the uterus is relaxed, that spiral artery pressure is, say, around 90 millimeters of mercury.
Right. So baseline pressure is about 90. What happens when that big contraction hits?
Well, during the peak of a strong contraction, the pressure inside the uterine muscle, the myometrial pressure, can shoot way up. Often it hits 120 millimeters of mercury, maybe even more.
Ah, so it exceeds the arterial pressure.
Exactly. That 120 millimeter Hg completely overcomes the 90 millimeter Hg in the spiral arteries. So the myometrial pressure literally pinches off those arteries, stopping the blood flow. Every single contraction acts like a temporary tourniquet.
Wow. Okay, so a mini apnea event with every contraction. A healthy baby can handle that, presumably.
A healthy fetus with good reserves, yes, it can cope with those brief pauses.
But where's the tipping point? When does that normal physiological stress turn into something pathological? When do we start talking about non-reassuring fetal status?
The stress really builds up from two main sources. First, like we said, those repeated contractions cutting off the uteroplacental circulation. Second, you often get cord compression.
Right, the cord getting squeezed.
Yeah, maybe because there isn't much amniotic fluid, oligohydramnios, or the baby's in an awkward position, that intermittently interrupts blood flow through the cord. So if the fetus already has compromised reserves, maybe due to placental problems or growth restriction, fetal growth restriction, or FGR, then those temporary oxygen dips push it over the edge into metabolic distress.
And that's when we use the term non-reassuring fetal status, NRFS.
Correct. We've moved away from the old term fetal distress. It was just too vague, didn't correlate well with actual outcomes. NRFS is more precise, more descriptive of what we're seeing on the monitor. Hashtag tag 1.2 methods of fetal monitoring.
So when we're assessing the baby, the simplest method, the sort of low-tech approach, is intermittent auscultation, IA. Just listening in with a stethoscope or a handheld Doppler.
Right, the clinical method. Using an ordinary stethoscope, a fetoscope, or more commonly now, a handheld Doppler device.
But even with a simple method, there's a strict protocol you have to follow, isn't there? It's not just casual listening.
Oh, absolutely not. Precision is key. The frequency of listening has to increase as labor progresses. So early on, maybe every 30 minutes.
Okay.
But once active labor, the first stage, is established, you tighten that up to every 15 minutes. And then in the second stage, the pushing stage, it's every 5 minutes.
Every 5 minutes in the second stage. Wow.
And it's not just when, but how. You need to listen for a full 60 seconds. And critically, listen immediately before and right after a contraction. You want to hear that heart rate recover back to its baseline.
Makes sense.
Mhm.
And what's considered the normal range for the fetal heart rate, the FHR?
The average is usually around 140 beats per minute. The generally accepted normal range is about 100 to 160 BPM. Though you'll see the FIGO, the International Federation of Gynecology and Obstetrics, standards sometimes narrow that a bit, maybe 110 to 150 BPM.
Okay, go 110 to 150 or 100 to 160, but IA has its limits, right?
Definitely. It's intermittent by definition, so you could easily miss brief but critical events happening between checks.
Like a sudden deceleration.
Exactly. Plus, there's human error. And it can be really difficult, sometimes impossible, to hear clearly during a strong contraction, or if the mother is obese, or if there's hydramnios, that's excessive amniotic fluid muffling the sounds.
Which naturally leads us to the more high-tech approach, continuous electronic fetal monitoring, EFM, or as most people know it, cardiotocography, CTG.
Right, the biophysical method. And this becomes necessary when there are specific risk factors that make fetal compromise more likely.
What kind of risk factors trigger the need for continuous EFM?
We think about both maternal and fetal factors. On the maternal side, things like chronic hypertension, preeclampsia, she's had a previous cesarean delivery, any antepartum hemorrhage, or premature rupture of membranes.
Right.
And for the fetus, if the baby is small, maybe fetal growth restriction, FGR, or if there's oligohydramnios, not enough fluid, or if it's a multiple pregnancy like twins or triplets, those situations warrant continuous monitoring.
And with EFM, there are two main ways to do it, external versus internal monitoring.
Correct. The external approach is non-invasive. You use an ultrasound Doppler transducer on the mom's abdomen to track the fetal heart rate, and you pair that with a tachydynamometer, another external sensor, which measures the timing and duration of contractions, though not their intensity accurately.
And the internal?
The internal method gives you much more precise data, but it's invasive. You need the membranes to be ruptured. A tiny spiral electrode, like a little corkscrew, is attached directly to the fetal scalp.
Wow, directly onto the baby's scalp.
Yes, it gives a very clear fetal electrocardiogram, or ECG, tracing. And alongside that, you can insert an intrauterine pressure catheter, an IUPC, into the uterus next to the baby. That gives you a true measurement of the intensity and resting tone of the contractions.
Okay, that's a big difference in data quality. Now, interpreting these CTG traces, this seems like the core skill. There's this three-tier system used by major bodies like ACOG, ARCOG. We need to really nail this down.
This is absolutely fundamental. It's the language we use to decide what to do. Let's break it down. Category I is normal or reassuring. This is the goal. Everything looks good.
What does good look like specifically?
All four key features are reassuring. You've got a baseline heart rate between 110 and 160 beats per minute. You've got moderate variability, which is an oscillation of 5 to 25 beats per minute around that baseline. You have either no decelerations or only early decelerations, which we'll get into. And importantly, accelerations are present. That's category I, basically. Green light.
Great, green light. Then category 2.
Category 2 is indeterminate or suspicious. This is the gray zone, the tricky one. The trace isn't category 1, but it's also not category 3, which is the really bad one.
So it defines it.
It means there's one non-reassuring feature, but the rest are okay. For instance, maybe you have minimal variability, less than 5 beats per minute wiggle, but it only lasts for, say, 40 minutes, maybe up to 90 minutes. Or you might see certain types of variable decelerations. Category 2 doesn't mean immediate panic, but it definitely means pay close attention, maybe do some extra tests, and be ready to act. It's a yellow light.
Got it. Increased vigilance. And then the red light, category 3.
Category 3 is abnormal or pathological. This is the crisis signal. This means urgent action is needed, often delivery. It's defined by a combination of bad signs. Specifically, you need absent baseline variability, basically a flat line with no wiggle, combined with either recurrent late decelerations, recurrent variable decelerations, persistent bradycardia, a very slow heart rate, or that really ominous pattern called the sinusoidal pattern.
Absent variability plus one of those bad deceleration patterns or bradycardia.
Precisely. That combination screams significant fetal hypoxia and metabolic acidosis. Time to intervene now.
Okay, let's dig deeper into that language of the fetus on the CTG. You mentioned variability, that baseline wiggle. Moderate variability, 6 to 25 BPM, is considered the hallmark of fetal well-being. Why is that oscillation so fundamental?
Variability is like a window into the fetal brain and how well it's oxygenated. It reflects the constant push and pull between the sympathetic nervous system, which wants to speed the heart up, and the parasympathetic system, mainly the vagus nerve, which slows it down.
The brake and the accelerator.
Kind of, yeah. When the baby is healthy and well oxygenated, both systems are active and firing, creating that constant healthy fluctuation, that moderate variability we look for. It tells you the central nervous system is intact and functioning well.
So conversely, reduced variability less than 5 BPM. That's a major warning sign. What kind of things dampen that down?
Several things can reduce variability, and it's crucial to know the difference. Some causes are benign, like the baby just being in a sleep cycle. Fetal sleep usually lasts less than 40 minutes, maybe an hour max. Or it could be certain medications given to the mother, things like pethidine, tranquilizers. Even atropine can cross the placenta and quiet the baby down temporarily.
Okay, sleep or meds. But the serious causes.
The really worrying causes are things like fetal hypoxia, lack of oxygen reaching the brain, or established metabolic acidemia, meaning acidosis has already set in. Prematurity can also cause lower variability and sometimes congenital problems like a heart block.
So how do you tell the difference?
Well, if you see reduced variability, especially if it's absent variability, and there are no accelerations either, and this pattern persists for, say, more than 90 minutes, that's highly suspicious for significant hypoxia. You need to investigate further, quickly.
And accelerations themselves, those brief speed-ups, at least 15 beats for 15 seconds. You said those are always good.
Always reassuring, yes. An acceleration is basically the fetus shouting, "I'm doing okay." It shows that the neurohormonal pathways and the cardiovascular system are intact and responsive. Seeing accelerations, whether they happen on their own or if you stimulate the baby, is a very reliable sign that the fetus is not currently acidotic.
Right. Now, the decelerations, you mentioned 3 basic types. Getting these straight seems absolutely critical for reading a CTG correctly. Let's nail down the differences.
Absolutely critical. Let's take them one by one. First, early decelerations, sometimes called type I dips. These are the benign ones.
Okay.
They look uniform, smooth, shallow. The key feature is that they perfectly mirror the contraction. The deceleration starts exactly when the contraction starts. Its lowest point, the nadir, matches the peak of the contraction, and it's back to baseline exactly when the contraction ends.
What causes them?
Simple head compression. As the uterus squeezes, the baby's head gets compressed, which triggers a vagal nerve response, slowing the heart rate temporarily. It's physiological, not pathological. No intervention needed.
Got it. Early means head compression. Mirrors the contraction, it's okay. Now, the dangerous one, late decelerations.
Second, late decelerations, or type 2 dips. These are the ones that really worry us because they indicate uteroplacental insufficiency. The placenta isn't delivering enough oxygen.
How do they look different?
They are also typically uniform and U-shaped, but the timing is completely different. They are delayed relative to the contraction. The critical point is that the deceleration begins after the contraction has already started, usually more than 20 seconds after. And its nadir, the lowest point, occurs after the peak of the contraction, often about 20 seconds later.
So there's a lag. Why the lag?
That lag reflects the physiology of placental failure. The contraction squeezes, oxygen transfer drops, the baby becomes hypoxic, the chemoreceptors in the fetus detect this lack of oxygen, and then the heart rate slows down. That sequence takes time, hence the delay. Seeing recurrent late decelerations suggests fetal hypoxia about 50% of the time. It demands immediate attention.
Okay, late means placental insufficiency. Delayed onset nadir, very concerning. What's the third type?
Third, variable decelerations. These are the most common type you'll see. They get their name because their shape, depth, and timing relative to contractions are highly variable.
And shape-wise.
They are often V-shaped, meaning a very abrupt drop in heart rate and a quick recovery. Sometimes U-shaped or W-shaped too. The cause is usually cord compression.
The cord getting squeezed intermittently.
Exactly.
As the baby moves or the uterus contracts, the umbilical cord gets squashed, temporarily cutting off blood flow. You often see little transient accelerations right before and right after the dip. We call these shoulders.
Shoulders are dead.
Shoulders generally indicate the fetus is still compensating well. But if variable decelerations become very deep, U-shaped, last longer than a few minutes, lose those shoulders, and occur with reduced baseline variability, that suggests the cord compression is severe and sustained, and the fetus is becoming acidotic.
Okay, variable means cord compression, variable timing, V-shaped usually. Watch out if they get deep, long, low shoulders. There's one more pattern you mentioned with category 3, the sinusoidal pattern. Ah, yes, the sinusoidal trace. This one is visually striking and very ominous.
What does it look like?
It looks like a sine wave on the trace. You have a stable baseline heart rate, but the variability is fixed or completely absent, and the heart rate oscillates smoothly up and down in this regular wave-like pattern. There are no accelerations.
How long does it need to last?
It needs to persist for more than 30 minutes to be truly classified as sinusoidal. It's strongly associated with severe fetal anemia, maybe from a fetal-maternal hemorrhage where fetal blood leaks into the mother's circulation, or ruptured vasa previa. It can also occur with severe fetal hypoxia and acidosis. It's a sign of a very sick baby. Hashtag tag 1.4 biochemical confirmation of acidosis.
So we have these patterns, but you mentioned EFM has a high false positive rate. A scary-looking trace doesn't automatically mean the baby is in dire straits.
Exactly. That's the huge clinical challenge. CTG is very sensitive. It picks up potential problems well, but it's not very specific. Many babies with abnormal traces are actually perfectly fine.
Which means we need a way to confirm if there's actual acidosis before rushing into, say, an emergency C-section.
Yeah.
Historically, that's been fetal scalp blood sampling, SBS.
Correct. SBS was the gold standard for corroboration for a long time. You need the cervix to be dilated, membranes ruptured. You insert an endoscope, make a tiny nick on the fetal scalp.
A nick on the scalp.
A very small 2 millimeter incision, yes. Then you collect a tiny blood sample, about 35 microliters, in a heparinized capillary tube and analyze the pH immediately.
And the interpretation is straightforward.
Pretty clear-cut. A pH less than 7.20 indicates significant fetal acidosis and usually means you need to deliver urgently. A pH above 7.25 is reassuring. The baby is likely okay despite the CTG trace. Between 7.20 and 7.25 is borderline, often requiring a repeat sample soon.
That sounds quite invasive, though, and probably takes time and skill.
It is, and it's becoming less common in many places, partly for those reasons. It also can't be done if the cervix isn't dilated enough.
So what about fetal ECG analysis? You mentioned looking at the ST segment, specifically the TQRS ratio. How does that help assess the baby's metabolic state?
This is a really interesting advancement, often integrated into the scalp electrode itself, the STAN technology. It looks beyond just the heart rate to the actual electrical activity of the heart muscle.
Okay, how?
It analyzes the shape of the fetal ECG waveform. The T wave represents the repolarization of the ventricles. When the heart muscle itself starts to suffer from lack of oxygen myocardial hypoxia, the T wave changes shape. It gets taller and wider. The system calculates the ratio of the height of the T wave to the height of the QRS complex.
And what's the normal ratio?
In a healthy, well-oxygenated fetus, the TQRS ratio is normally less than 0.25. If the fetus becomes significantly hypoxic and starts developing metabolic acidosis, this ratio tends to increase significantly and persistently.
So a rising TQRS ratio plus a worrying CTG trace is a strong signal.
It's a very strong indicator of developing metabolic acidosis, reflecting stress on the heart muscle itself. And studies have shown that using ST analysis alongside CTG can actually help reduce the rate of operative deliveries for non-reassuring fetal status compared to using CTG alone. It adds specificity.
Because it helps confirm the CTG findings are metabolically significant.
Precisely. It helps sort out the false positives.
And then, after the baby's born, the final confirmation comes from the umbilical cord blood gases.
That's the definitive look back, yes. Taking samples from both the umbilical artery and vein gives you the full picture of the baby's acid-base status at the moment of birth. A cord artery pH less than 7.0 combined with a large base deficit, say greater than 12 millimoles per liter, indicates profound metabolic acidemia.
And that level of acidosis correlates with problems after birth.
Strongly correlates with the risk of neonatal complications, including potential multi-organ dysfunction. It confirms the severity of the intrapartum stress.
Okay, let's shift gears now. We've talked about fetal hypoxia and acidosis. That same underlying failure pathway, inadequate oxygen delivery leading to acidosis, can happen in the mother too, when she experiences shock. Hashtag 2.1, defining shock and microcirculatory failure.
Absolutely. Shock, in essence, is the ultimate crisis of the circulatory system. The formal definition is a state of circulatory inadequacy leading to poor tissue perfusion and generalized cellular hypoxia.
So not enough oxygen getting to the cells everywhere.
Exactly. And fundamentally, it's a mismatch. The amount of circulating blood volume just isn't enough to fill the capacity of the vascular system, the circulatory bed. The end result is stagnation of blood flow, buildup of carbon dioxide and metabolic waste products, severe metabolic acidosis, and ultimately, if it's not reversed, cell death.
You mentioned the microcirculation earlier, how blood is rerouted in shock. Can you walk us through that anatomy of failure again? How does the body try to prioritize?
It's a fascinating built-in triage system. In the microcirculation, you have these networks of tiny capillaries where nutrient exchange happens. These beds are controlled by little muscular rings called pre- and post-capillary sphincters.
Like little gates?
Exactly. But there's also a shortcut, a direct channel called a metarterial shunt, or sometimes a thoroughfare channel, that allows blood to bypass the main capillary bed entirely.
Okay.
When shock hits, the sympathetic nervous system goes into overdrive. It signals these sphincters, particularly the precapillary ones initially, to constrict tightly, shutting down blood flow to less essential capillary beds like in the skin or the gut.
And the blood takes the shortcut.
Yes, the blood gets shunted through that metarterial bypass directly towards the vital organs that absolutely need perfusion: the brain, the heart, the kidneys. So the early compensatory phase of shock is all about this massive vasoconstriction and shunting to protect the core. Hashtag tag 2.2 pathophysiology of hypovolemic versus endotoxic shock.
In obstetrics, the two big players are usually hypovolemic shock, mostly from hemorrhage, and septic shock from infection, which is also called endotoxic shock.
Yeah.
They both lead to poor perfusion, but the underlying mechanisms are quite different, aren't they?
Vastly different, yes. Let's start with hypovolemic shock or hemorrhagic shock. Here, the problem is simple but devastating: loss of blood volume.
Just not enough fluid in the pipes.
Right. The body's immediate reaction is a massive neuroendocrine and sympathoadrenal response. You get a surge of stress hormones, ACTH, adrenocorticotropic hormone, GH, growth hormone, cortisol, glucagon, plus a huge release of catecholamines, adrenaline, and noradrenaline. Everything is geared towards vasoconstriction, trying to maintain blood pressure despite the falling volume.
Okay, pure volume loss triggering a squeeze. Now, contrast that with endotoxic shock or septic shock. The trigger here is infection, usually bacterial.
Correct, and typically gram-negative bacteria like E. coli are common culprits, maybe 75–80% of the time. The key villain is the endotoxin, a component of the bacterial cell wall, specifically lipopolysaccharide.
And what does that endotoxin do?
It triggers a catastrophic inflammatory cascade. It activates white blood cells, leukocytes, and the complement system. This unleashes a storm of inflammatory mediators, destructive enzymes like proteases, damaging free radicals like superoxide and hydroxyl radicals, and powerful signaling molecules called cytokines, especially interleukins, ILs, and tumor necrosis factor, TNF.
An inflammatory firestorm. What does that do to the blood vessels?
It causes chaos. These mediators damage the lining of the blood vessels, the endothelium, making them incredibly leaky. You get widespread capillary permeability. Plus, specific mediators have potent vascular effects. Prostacyclin, for example, causes massive vasodilation.
So blood pressure drops.
Dramatically. And then you have thromboxane A2, which does the opposite in the lungs. It causes pulmonary vasoconstriction and makes platelets clump together. But systemically, the overwhelming effect is vasodilation, largely driven by the release of nitric oxide, NO, which used to be called endothelium-derived relaxing factor, or EDRF.
Nitric oxide causing vasodilation.
Yes, massive, sustained, profound systemic vasodilation. This leads to that characteristic clinical picture you sometimes see in early septic shock, what we call warm shock.
Warm shock.
Yeah, the patient might actually feel warm, look flushed, skin is dry, but they're hypotensive because all their peripheral vessels are wide open. They might even be alert initially. But as it progresses and the body tries desperately to compensate with sympathetic drive, or if fluid leaks out and volume depletes, it transitions to cold shock.
Ah, like hypovolemic shock.
Similar presentation, yes. Now the periphery clamps down, the skin becomes cold, clammy, maybe ashen gray, pulses are weak, that's the late decompensated stage. Hashtag tag 2.3, the 4 phases of hemorrhagic shock.
Let's go back to hemorrhagic shock for a moment. Understanding its progression is crucial for knowing when intervention is most effective. Can we walk through those 4 classic phases, from reversible to irreversible?
Yes, this framework is really helpful clinically. The first phase is considered reversible. This is purely the initial compensation. Increased sympathetic activity, catecholamine release. The body is basically masking the blood loss. Vital signs might still be relatively stable.
Okay, phase 1, compensation is working. Phase 2.
The second phase is also generally reversible, but compensation is now maximal. You get excessive sympathetic stimulation causing constriction of both the pre- and the post-capillary sphincters. Clinically, this is when you usually start seeing clear signs: hypotension, tachycardia. But if you stop the bleeding and give fluids and blood now, the patient usually recovers well.
Right, still salvageable. But phase 3 is where things get really dangerous. It's called correctable, but it sounds like the point of no return is approaching fast.
It is. This is where the microcirculation starts to irreversibly fail. The key event is prolonged tissue anoxia leading to severe lactic acidosis.
The buildup of lactic acid.
Yes. And that acidosis has a critical paradoxical effect. It causes the precapillary sphincters to relax and open up because they're sensitive to acid. But the postcapillary sphincters remain constricted due to the ongoing intense sympathetic drive.
So blood flows in but can't get out of the capillaries?
Precisely. Blood pools and stagnates in the capillary beds. The pressure builds up, fluid starts leaking out due to endothelial damage from the hypoxia and acidosis, and you start seeing microthrombi forming the beginnings of DIC, disseminated intravascular coagulation. Capillary permeability skyrockets. It's correctable with massive effort, but the damage is mounting.
And if that effort fails or comes too late, we hit phase 4.
The fourth phase, irreversible shock. At this point, the damage is too widespread. The postcapillary sphincters might still be constricted, or they might fail entirely, leading to complete vascular collapse. Blood is stagnant. Fluid has leaked massively into the tissues.
So giving copy fluids now doesn't help much.
It often doesn't restore circulating volume effectively because it just leaks straight out of the damaged capillaries. This phase is defined by a catastrophic loss of systemic vascular resistance, SVR, severe depression of heart muscle function, profound and unresponsive hypotension, and the onset of multiple organ system failure, or MODS. The cellular damage is done, and mortality is incredibly high. Hashtag tag 2.4 management of shock, hemorrhagic, and endotoxic.
Okay, so knowing those phases emphasizes the urgency. Let's talk management. For hemorrhagic shock, the principles seem clear. Stop the bleeding, replace the volume.
Simple to say, hard to do sometimes, but yes, those are the absolute priorities. Stop the source of bleeding surgically, medically, whatever it takes, and replace volume aggressively.
What kind of fluids?
You start immediately with crystalloids, usually normal saline or lactated ringers. They're readily available, cheap, but they distribute quickly throughout the total body water, so a lot leaks out of the vessels. You need to give large volumes, often 3 liters of crystalloid for every 1 liter of estimated blood loss.
Okay, what about colloids?
Colloids, like albumin, or synthetic ones like polygelatin solutions, have larger molecules, so they tend to stay in the intravascular space longer and pull fluid in. They can be useful for volume expansion. However, we specifically need to avoid dextrans, as they can interfere with blood clotting and cross-matching.
And crucially, replacing red blood cells.
Absolutely essential to restore oxygen carrying capacity. We use packed red blood cells, PRBCs, usually combined with crystalloids like saline. And while you're doing all this, you're monitoring vital signs like crazy, aiming for specific targets.
What targets?
You want to maintain a systolic blood pressure, ideally above 90 millimeters of mercury, and a mean arterial pressure, MAP, above 60 millimeter Hg to ensure vital organ perfusion. If you have central monitoring, a central venous pressure, CVP, between, say, 8 and 15 centimeters of water suggests adequate volume replacement, though CVP is less reliable as a sole guide now.
Okay, that's hemorrhagic shock now, endotoxic or septic shock management. The focus shifts a bit, right? It's not just fluids, it's infection and inflammation.
Right. It's a 3-pronged attack. 1, hemodynamic stability, fluids, maybe vasopressors. 2, aggressive supportive care for organ dysfunction. 3, source control, find and eliminate the infection.
Antibiotics are key then.
Non-negotiable and immediate. You need broad spectrum coverage right away, hitting gram-positives, gram-negatives, and anaerobes until you get culture results back. A common starting combo might be something like ampicillin, gentamicin, and metronidazole.
And the hemodynamic goals, are they different from hemorrhagic shock?
Slightly higher targets usually. We often aim for a MAP closer to 70 millimeter Hg or higher. CVP targets might be similar, maybe 10 to 12 centimeter H2O, ensuring adequate preload. And urine output is a critical marker of perfusion. You absolutely want to see at least 0.5 milliliters per kilogram per hour.
What if fluids alone don't bring the pressure up? That's common in septic shock due to the vasodilation.
That's when you reach for inotropes and vasopressors. These are drugs that squeeze the blood vessels or make the heart pump harder. Norepinephrine is often the first-line vasopressor. Dobutamine can be added if cardiac output is low.
What about dopamine? It used to be common.
Dopamine is generally avoided now, especially in high doses, because it carries a significant risk of causing cardiac arrhythmias, which you really don't need in an already unstable patient.
Makes sense. And corticosteroids, you mentioned them earlier.
Yes, there's a role for corticosteroids like hydrocortisone,
Mhm.
particularly if the patient remains hypotensive despite fluids and vasopressors, suggesting potential adrenal insufficiency related to critical illness, sometimes called CIRSI, critical illness-related corticosteroid insufficiency, or in the context of severe systemic inflammatory response syndrome, SRS. The idea is they might help stabilize membranes, reduce inflammation, and improve vascular responsiveness. Dose might be around 50 milligrams IV every 6 hours, for example.
Any other advanced therapies?
For very severe sepsis, especially with evidence of coagulopathy, DIC, activated protein C drotrecogen alpha was used for a time. It has anticoagulant, anti-inflammatory, and profibrinolytic effects. However, its use has become much more restricted due to bleeding risks and reevaluation of its overall benefit, so it's reserved for very specific severe cases, if used at all now.
So, the circulatory collapse of shock almost inevitably damages other organs. Let's focus on two of the most immediate and life-threatening consequences: the kidney shutting down, AKI, and the clotting system falling apart, DIC, hashtag 3.1. Acute kidney injury, AKI, and obstetrics.
Right. Acute kidney injury, AKI, isn't just the kidneys aren't working well. It has a specific definition based on measurable changes.
What are the criteria?
It's defined primarily by a significant drop in urine output, that's oliguria, typically less than 400 milliliters over 24 hours, or maybe more precisely, less than 0.5 milliliters per kilogram per hour for at least 6 hours. And that's coupled with a rise in serum creatinine, the waste product kidneys filter out.
How much of a rise?
Either an absolute increase of 0.3 milligrams per deciliter or more from the patient's baseline, or a relative increase to 1.5 times their baseline level or higher. That combination signals acute kidney injury.
And in pregnancy, what are the specific things that tend to trigger AKI?
We think about causes in 3 categories: prerenal, not enough blood flow to the kidney; intrinsic, damage within the kidney itself; and postrenal, blockage after the kidney. In obstetrics, prerenal causes are super common, usually due to massive hemorrhage like postpartum hemorrhage, PPH, or bad placental abruption. Severe dehydration from hyperemesis gravidarum or shock from a septic abortion can also do it.
And intrinsic causes, damage to the kidney.
Those are often linked to specific pregnancy complications and can be very serious. Severe preeclampsia, especially HE-LOP syndrome, that's hemolysis, elevated liver enzymes, low platelet count, can directly damage the kidneys. Another rare but devastating one is acute fatty liver of pregnancy, AFLP. These conditions cause direct injury to the kidney structures.
Within that intrinsic damage, you mentioned a critical distinction: acute tubular necrosis, ATN, versus acute cortical necrosis, ACN. Why is that so important?
It's crucial because it dictates the prognosis whether the kidney function can recover or not. Acute tubular necrosis, ATN, is the most common type of intrinsic AKI we see, often after prolonged ischemia from shock or sepsis.
What part of the kidney is damaged?
The damage is primarily to the tubules, the little pipes within the kidney, particularly starting in a section called Henle's loop. The good news about ATN is that the underlying structure, the glomeruli and blood vessels, are often preserved. So if the patient survives the initial insult, the tubular cells can regenerate and kidney function can recover, often fully, usually within 1 to 2 weeks. It's reversible.
Okay, ATN is bad, but usually reversible. What about ACN?
Acute cortical necrosis, ACN, is the disaster scenario. Thankfully, it's much rarer, but it's typically associated with the most severe obstetric catastrophes, like major placental abruption or profound endotoxic shock.
And the damage here is different.
Yes, the damage here is to the blood vessels supplying the outer part of the kidney, the cortex, specifically the glomerular afferent arterioles. These are end arteries, meaning they don't have backup supply routes. Severe spasm or clotting in these vessels leads to irreversible death of the entire cortex.
Irreversible. How is it diagnosed?
It can be suspected clinically, but often confirmed with imaging. A contrast-enhanced CT scan, CECT, might show the characteristic rim sign where only the outer rim of the kidney enhances, indicating cortical death. Because the damage is permanent, these patients unfortunately usually require lifelong dialysis or a kidney transplant.
A devastating outcome. Now, managing AKI when the patient is in the anuric phase, meaning making no urine, you said fluid balance, is walking a knife edge. Why is overhydration so dangerous?
It's incredibly dangerous because if the kidneys can't excrete fluid, Any excess fluid you give backs up in the system. It leads to pulmonary edema fluid in the lungs, making it impossible to breathe and congestive heart failure. In critical care for AKI, the mantra really is, the danger of slight dehydration is far less than the danger of slight overhydration.
So how do you manage fluids? Extremely carefully, I assume.
Meticulously, you track every single milliliter in and out. The total fluid allowance is severely restricted. You typically give a baseline amount for insensible losses, water loss through breathing, skin, stool, which is around 500 milliliters per day. Then you add back volume equivalent to any measured losses, like from vomiting or diarrhea, and you add back the volume of any urine they do produce, if any. That's it, no more.
Wow, very strict. What about nutrition during this phase?
Nutrition is also critical, partly to provide calories, but also to minimize waste production. The goal is around 1,500 to 2,000 kilocalories per day. But crucially, protein intake must be restricted,
Why restrict protein?
because the breakdown of protein produces urea and potassium, which the failing kidneys can't excrete. So restricting protein reduces the buildup of these toxic substances. To prevent the body from breaking down its own muscle protein for energy, which also produces urea and potassium, you need to provide adequate non-protein calories, primarily carbohydrates. Giving about 100 grams of glucose or carbohydrate per day can significantly minimize protein catabolism and thus slow down the rise in urea and potassium.
Oh, using carbs to spare protein. Smart. Speaking of potassium, hyperkalemia, high potassium is the big killer in AKI, right? Because of the heart effects.
It's the most immediately life-threatening electrolyte abnormality, yes. High potassium levels destabilize the heart's electrical activity and can lead to fatal arrhythmias or cardiac arrest.
So how do you treat it emergently?
It's a multi-step emergency. First, you need to stabilize the cardiac membrane immediately. That's done by giving intravenous calcium gluconate, usually 10 milliliters of 10%. This doesn't lower the potassium level, but it protects the heart from its effects.
Okay, step 1, protect the heart. Step 2.
Step 2. Shift potassium out of the bloodstream and into the cells. The fastest way to do this is with intravenous glucose and insulin. Typically, you give a bolus of concentrated dextrose, like 50 milliliters of 50% dextrose, along with 10 units of regular insulin. The insulin drives potassium into the cells along with the glucose. This works quickly, but is temporary.
Buys you time.
Exactly. Buys you time while you work on step 3, actually removing potassium from the body. This can be done using potassium-binding resins given orally or rectally, which bind potassium in the gut so it's excreted in the stool. Or, more definitively, through dialysis. Other measures like beta agonists, like albuterol nebulizers, can also help shift potassium into cells, and bicarbonate might be used if severe acidosis is also present.
Which brings us to dialysis. When is it absolutely necessary?
Dialysis, either hemodialysis or peritoneal dialysis, becomes necessary when the complications of AKI become unmanageable with medical therapy. The main indications are severe, symptomatic uremia, the buildup of waste products, dangerously high potassium, hyperkalemia, maybe 6.5 LEQL, that isn't responding to treatment, severe metabolic acidosis, say bicarbonate 13 NaQL, or significant fluid overload causing respiratory distress.
And dialysis in a pregnant patient adds extra challenges.
It does. You need continuous electronic fetal monitoring during the dialysis run because the fluid shifts and changes in electrolytes can potentially stress the fetus or even trigger preterm labor. There's a theory that dialysis might remove progesterone, which helps maintain pregnancy, possibly contributing to the risk of labor.
Okay, the other major systemic failure we see after shock or severe obstetric events is the complete breakdown of clotting. Disseminated intravascular coagulation, DIC. You mentioned it's also called consumptive coagulopathy.
Yes, and that name really captures the essence of it. DIC isn't primarily a bleeding disorder, it's a clotting disorder gone wild. It's characterized by widespread, inappropriate activation of the coagulation cascade, leading to massive fibrin deposition in small blood vessels throughout the body.
So the body forms clots everywhere.
Tiny clots, yes, in the microvasculature. This consumes huge amounts of clotting factors and platelets. So paradoxically, this massive clotting process uses up all the resources needed for normal hemostasis, leading to a state where the patient can then bleed uncontrollably from anywhere. Clotting leads to bleeding.
And pregnancy itself kind of sets the stage for this.
It does. Pregnancy is naturally a hypercoagulable state. Levels of many clotting factors like factor I, fibrinogen, 7, 8, MyX, and X are significantly increased. At the same time, the body's natural clot-busting system, fibrinolysis, is somewhat suppressed. This is likely protective against hemorrhage at delivery, but it means the system is primed, almost spring-loaded, making it easier to tip over into pathological clotting like DIC if a major trigger occurs.
What are the main triggers in obstetrics that can set off this DIC cascade?
There are several, but three classic ones illustrate different mechanisms and speeds. First, abruptio placentae, or placental abruption. When the placenta tears away prematurely, the large blood clot that forms behind it and the damaged placental tissue, decidua, release massive amounts of tissue factor, or thromboplastin, directly into the maternal circulation. This acts like dumping gasoline on the coagulation fire, rapidly consuming clotting factors and platelets, causing acute DIC.
Okay, abruption is a rapid acute trigger. What else?
Second, amniotic fluid embolism. AFE. This is perhaps the most dramatic and explosive trigger. Amniotic fluid, which is rich in thromboplastin-like substances and fetal debris, somehow enters the maternal circulation, often during tumultuous labor or delivery. It causes an immediate catastrophic reaction, blockage of pulmonary arteries, cardiovascular collapse, and profound instantaneous DIC. If the patient survives the initial pulmonary assault, they often develop massive secondary fibrinolysis where the body tries to break down all the clots, further depleting fibrinogen and factors V and 8, leading to severe hemorrhage.
AFE sounds terrifyingly fast. The third one.
Third is retained dead fetus syndrome. This is a much slower, more insidious process. If a fetus unfortunately dies in utero and is retained for several weeks, typically more than 4 weeks, thromboplastin-like material from the decomposing fetus and placenta gradually leaks into the maternal circulation over time. This leads to a slow, chronic consumption of clotting factors, particularly fibrinogen, a process called slow defibrillation. The patient might not have acute symptoms initially, but their clotting system is being steadily depleted, putting them at high risk of hemorrhage if they go into labor or have surgery.
So acute triggers like abruption and AFE, and a chronic one like retained fetus.
Yeah.
How do you diagnose DIC quickly, especially when things are happening fast?
Often, the clinical picture, unexpected, profuse bleeding from IV sites, wounds, gums, combined with signs of shock or organ failure in the context of a known trigger, strongly suggests DIC. But lab tests are crucial.
What's the first thing you might do?
A very simple, quick bedside test is the clot observation test. Just draw a tube of the patient's blood without anticoagulant and watch it. Normally, it should form a stable clot within about 5–10 minutes. If no clot forms at all after, say, 30 minutes, it gives you a rough but rapid indication that the fibrinogen level is critically low, likely less than 100 milligrams per deciliter.
A quick and dirty check. What about lab tests?
Standard coagulation tests are essential. Prothrombin time, PT, activated partial thromboplastin time, APTT, are usually prolonged because factors are consumed. Platelet count will be low, thrombocytopenia, fibrinogen level will be low, but perhaps the most valuable and rapidly reflective test in acute DIC is the thrombin time, TT.
Why the thrombin time?
Because thrombin's job is to convert fibrinogen into fibrin, the final step in clot formation. If fibrinogen is severely depleted, or if fibrin degradation products from clot breakdown are present and interfering, the thrombin time will be significantly prolonged. It directly reflects the lack of the final substrate needed to clot.
Any other useful tests?
Looking at a peripheral blood smear under the microscope can be helpful. You might see schistocytes. These are fragmented, helmet-shaped red blood cells that have been physically sheared as they try to squeeze past the fibrin strands deposited in the small blood vessels. Seeing those, along with low platelets, is very suggestive of DIC. You also measure fibrin degradation products, FDPs or D-dimer, which are elevated because the body is trying to break down all the clots being formed.
Okay, diagnosis relies on clinical picture plus labs, showing low platelets, low fibrinogen, prolonged clotting times, and maybe schistocytes.
Yeah.
How do you treat it? It sounds like you need to replace what's being consumed.
That's exactly the core principle.
Yeah.
Replace the missing components. The goal is to rapidly get the platelet count above a safe level, usually considered 50,000 per microliter, and the fibrinogen level above 100 milligrams per deciliter, to allow effective clotting to occur at sites of bleeding.
So what blood products do you use?
Component therapy is key. Whole blood is rarely used anymore. You give fresh frozen plasma, FFP. FFP contains all the soluble clotting factors, including the label ones like factor V and factor 8, as well as factor 11-12, and importantly, antithrombin III, a natural anticoagulant that gets consumed in DIC.
Okay, FFP for factors. What about fibrinogen specifically?
For targeted fibrinogen replacement, cryoprecipitate is the product of choice. It's made from FFP but concentrated, so you get a lot of fibrinogen, factor 8, von Willebrand factor, and factor 30 in a much smaller volume than FFP. This is crucial if you're worried about fluid overload.
And platelets.
You give platelet concentrates to raise the platelet count. It often takes multiple units, maybe 5 to 10 units, to get a significant increase in the platelet count in an adult with consumptive thrombocytopenia.
Is there a standard recipe for giving these products in a massive hemorrhage situation involving DIC?
Yes, many institutions have adopted a massive transfusion protocol, MTP. The idea is to give blood components in a balanced ratio early on, rather than just pouring in red cells and crystalloids and waiting for the coagulopathy to become severe. A common ratio aims to mimic whole blood somewhat, maybe 6 units of packed red blood cells, 4 units of FFP, 1 unit of single donor platelets or equivalent pool. That 6.4.1 ratio is a common starting point, adjusted based on ongoing lab results and clinical response. It helps prevent the dilutional coagulopathy that happens when you only replace red cells in volume.
Makes sense to replace everything that's being lost or consumed. What about heparin? It's an anticoagulant. Does it have any role when the patient is paradoxically bleeding due to clotting?
That's a really tricky area. In general, in acute, rapidly evolving DIC with active bleeding, like from abruption or AFE, heparin is contraindicated because it will almost certainly worsen the hemorrhage.
Okay, no heparin in acute bleeding DIC. When might it be used?
Its use is very limited and cautious. It might be considered in the specific situation of that slow, chronic DIC associated with a retained dead fetus, where the primary process is ongoing slow clotting without major active bleeding yet. The idea is to interrupt the slow consumption of factors before delivery or intervention. It might also have a theoretical role very early in amniotic fluid embolism to try and block the initial massive thromboplastin surge. But this is highly controversial and rarely done given the immediate cardiovascular collapse. But for the typical acute DIC scenario with bleeding, the focus is replacement, replacement, replacement.
Okay, stepping back from the acute crises for a moment. The best way to manage these emergencies is often to anticipate them. Identifying high-risk pregnancies seems key. #tag 4.1, identifying and managing high-risk cases.
Absolutely. Prevention and preparation are paramount. The numbers really tell the story. Something like 20 to 30% of pregnancies are classified as high risk. But this relatively small group accounts for a hugely disproportionate share of the bad outcomes, maybe 70 to 80% of perinatal mortality and morbidity.
So who falls into that high-risk category? How do we screen for them?
Screening involves looking at several areas. First, the patient's history. Maternal age is a factor very young, say under 16 or older, often considered over 30 or 35. Grand multiparity, having many previous births. A history of previous obstetric complications is a huge red flag. Things like previous postpartum hemorrhage, PPH, a prior stillbirth, or having delivered a baby with intranodal growth restriction, IUGR. Pre-existing medical conditions like hypertension or diabetes are also major risk factors.
Okay, history is key. What about the physical examination?
Yes, examination findings matter too. Maternal height can be relevant, particularly in some populations. For example, a height less than 145 centimeter might indicate a higher risk of cephalopelvic disproportion and difficult labor. Body mass index, BMI, abnormalities, either very low or very high obesity, increase risks. Obviously, high blood pressure detected during pregnancy, and assessment of the pelvis for adequacy.
And risks can also develop during labor itself.
Definitely. Complications arising during labor immediately put the patient into a higher risk category. Things like premature rupture of membranes, PROM, prolonged labor that isn't progressing, the presence of meconium staining in the amniotic fluid, or, as we discussed extensively, developing an abnormal fetal heart rate pattern on monitoring.
So once a patient is identified as high risk, what's the management strategy?
The core strategy involves 2 main things: referral and concentration. High-risk cases should ideally be managed in specialized centers that have the expertise and resources experienced obstetricians, anesthesiologists, neonatologists, blood bank support, and ICU capability, all readily available 2004/7. Concentrating these complex cases in dedicated centers improves outcomes.
And ideally, management starts even before pregnancy.
That's the gold standard. Preconception counseling and investigation are incredibly important for women with known risks. This might involve investigations like hysterography to look for uterine anomalies, optimizing management of chronic conditions like hypertension or diabetes before conception, or surgically repairing things like previous deep cervical tears. Early assessment in pregnancy is also vital. And during labor, for those needing intervention, there should be adherence to targets like the decision to delivery interval, DDI, aiming for 30 minutes or less from the decision for cesarean due to fetal compromise to the actual delivery. Hashtag 4.2 critical care and obstetrics ICU management.
But even with the best planning, some patients will deteriorate and require intensive care unit ICU level care. What are the triggers, the objective criteria that say this patient needs to be in the ICU?
ICU admission is generally indicated when the patient requires significant cardiovascular or respiratory support, or when they have multisystem organ failure. Looking at the data for obstetric ICU admissions, the majority, maybe around 75%, are actually admitted postpartum,
Postpartum, why then?
primarily driven by complications like severe hemorrhage, sepsis syndrome developing after delivery, or complications of severe preeclampsia or eclampsia.
Are there specific vital sign thresholds or lab values that mandate ICU admission?
Yes, there are objective parameters that often trigger an ICU consult or admission. These include things like extreme heart rates, for example, HR less than 40 BPM or greater than 150 BPM, severe hypotension, for example, systolic BP less than 80 millimeter Hg, or severe hypertension, e.g., diastolic BP greater than 120 millimeter Hg despite treatment, respiratory failure indicated by low oxygen levels, example, PO2, the partial pressure of oxygen in arterial blood, less than 50 millimeter Hg on supplemental oxygen, or severe acid-base disturbances, VGPH less than 7.1 or greater than 7.7. These are signs of impending or established critical illness.
And we need to remember that pregnancy changes normal values,
Right.
which might affect how we interpret these numbers in an obstetric patient.
Absolutely critical point. The normal physiological reference ranges are different in pregnancy. For instance, due to pregnancy-induced hyperventilation, the normal partial pressure of carbon dioxide, PCO2, is lower in pregnant women, typically around 27 to 34 millimeter Hg compared to non-pregnant levels. Correspondingly, the arterial pH is slightly more alkaline, usually between 7.40 and 7.47.
So a PCO2 of 40, normal for non-pregnant, might indicate respiratory compromise in a pregnant patient.
Exactly. You have to interpret all the hemodynamic and respiratory parameters within the specific context of pregnancy physiology. Applying non-pregnant norms can lead you to miss developing problems.
When a critically ill pregnant woman is in the ICU, what's the approach regarding the fetus? It must be incredibly difficult balancing maternal and fetal needs.
The universally accepted principle is clear. Maternal stabilization takes absolute precedence. Fetal interests are secondary when the mother's life is at immediate risk.
What does that mean practically?
It means that necessary maternal treatments, life-saving medications like sedatives, potent antihypertensives like beta blockers, essential antibiotics, or diagnostic procedures like CT scans or MRIs, should not be withheld or delayed solely out of concern for potential fetal effects if they are deemed critical for maternal survival or diagnosis.
That's a tough ethical line, but clear.
It has to be. However, that doesn't mean fetal well-being is ignored. It's standard practice, for example, to administer antenatal corticosteroids to the mother if preterm delivery before 34 weeks seems likely, even if she's critically ill, because the benefit of improved fetal lung maturity is well established. It's about balancing necessary maternal care with known fetal benefits where possible.
Finally, the most extreme scenario, maternal cardiac arrest. There's the concept of the perimortem cesarean delivery.
Yes, this is a specific time-critical intervention considered during maternal cardiopulmonary resuscitation, CPR, in the third trimester.
What's the time frame?
The general consensus, often called the 4-minute rule, suggests that if spontaneous circulation is not restored within 4 minutes of initiating high-quality CPR in a woman with a potentially viable fetus, usually considered 24 weeks gestation, preparations for an immediate cesarean delivery should begin, aiming for delivery by 5 minutes.
Why is it done? Is it primarily for the baby?
It's actually done for both maternal and fetal benefit. For the mother, delivering the fetus and placenta can relieve aortoco-vul compression caused by the gravid uterus. This can significantly improve venous return to the heart and potentially increase the effectiveness of CPR, giving the mother a better chance of resuscitation. And of course, for the fetus, prompt delivery offers the best chance of survival if the mother cannot be resuscitated quickly. #outro.
Wow, okay, so what does this all really mean? We've covered a huge amount of ground, taking this really deep dive through the critical pathways in obstetrics.
Yeah.
We started right at the beginning with detecting the first signs of trouble that drop in oxygen delivery shown by fetal monitoring.
Right, that initial hypoxia.
And we saw how, if that's not managed, it leads down this cascade to circulatory crisis, which we define as shock, and then how that shock triggers potentially catastrophic systemic failures, the kidneys failing with AKI, and the clotting system collapsing in DIC.
And the key takeaway, I think, the real synthesis here is understanding how interconnected all these processes are. It highlights why anticipating these cascades is so vital, and it also reinforces the importance of using corroborating evidence in our
You
monitoring.
mean like not relying solely on the EFM tracer?
Exactly. We know continuous EFM is a powerful screening tool. Studies do show it reduces the rate of neonatal seizures, for instance, by about 50% compared to intermittent auscultation. But we also hammered home its major limitation, that low specificity, the high false positive rate.
Which leads to unnecessary interventions.
It can. The data shows that continuous EFM use is associated with significantly higher rates of operative delivery, something like a 63% cesarean rate and a 15% operative vaginal delivery rate in some studies looking at abnormal traces. That's why those ancillary tests we discussed, fetal scalp pH sampling back in the day, or newer methods like fetal ECG ST segment analysis are so clinically important. They help confirm if the worrying trace actually reflects metabolic compromise, potentially avoiding unnecessary surgery.
So understanding that whole sequence from the cell-level hypoxia right up to managing multi-organ failure and knowing the limitations of our tools, that really defines elite-level practice in this field. But thinking ahead, where does this take us?
Well, that leads to a really interesting, maybe provocative final thought. It's rooted back in the fundamental biology of pregnancy. Think about the incredible immunological puzzle of pregnancy itself, right?
How the mother's immune system doesn't reject the fetus, even though it's essentially half foreign, a partial allograft with paternal antigens.
Exactly. It's a masterpiece of immune tolerance. Now, we also know that many of the critical conditions we've discussed, particularly things like severe preeclampsia, have strong links to underlying immunological dysfunction. The maternal immune system seems to be misfiring or reacting inappropriately.
Okay. Yeah.
So the provocative question is this. As we get better and better at understanding how that maternal immune tolerance normally works, could we potentially develop targeted immunological therapies in the future? Could treatments aimed at restoring or modulating that immune balance eventually replace some of our current, more traditional interventions for conditions like preeclampsia, where the root cause might be immunological?
Wow. Moving from managing the downstream effects like hypertension or seizures to actually fixing the underlying immune problem.
Precisely. That's where critical care knowledge might eventually merge with preventative medicine, targeting the fundamental biological triggers of these devastating obstetric emergencies. It's certainly something to think about for the future of the field.